we're getting to the fun stuff. I apologize. So evaluation and treatment, what's important is to understand that this is a spectrum of disease, and it progresses from being overweight to being type 2 diabetic. And the best measurement in my office to evaluate a patient is their body measurements. What's their weight? What's their body fat? What's their BMI? Normal BMI is under 25. You're obese if you're 30 to 35 and above. As we were taught, we do a full medical history, evaluate for family history, but virtually everybody has these risk factors in their family. You can find it. We do measurements in our office, but again, I said that the body fat and the body weight is more important to me than these numbers, because I can tell you what these numbers are going to be when I see the patient. But we do a 2-hour glucose tolerance test. Medicare actually has encouraged us to do this more and more on patients that are at risk, and that's actually a pretty good tool. And then these are the other markers of inflammation, as I refer to them, to see what's going on with the rest of the body. So the treatment, here's the fun part. I'm an allopathic physician, and I came here to tell you that the food is the medicine. It's not about the pills. It's about the food. And the nutritional guidelines, again, are based on the food metabolism that we talked about. And it would make sense that if we remove the fuel, the dietary carbohydrates, we're going to treat these conditions. What does that do when we now reduce carbohydrates in the diet? We're going to turn off that insulin switch. Stored energy is going to be released from the adipose tissue. It's going to break down body fat. We lose weight. We empty that inflammatory gas tank. It controls hunger and appetite. It gives us a sense of fullness, and all by itself, this is working. We consume less calories without even realizing it. And again, I have to point out that dietary fats and protein are not the driving force. And remember, we talked about avoiding fats and cholesterol for 60 years? When you look at it in terms of insulin resistance, the fat and the cholesterol become less of an issue, and I'll come back to that. Also, the emphasis is not on the quantity or the calories or the portions. It's a physiologic effect. If you eat the right food, the food is the medicine that regulates the appetite, and then it will control your appetite. So we give patients tools to focus on carbohydrate content of food, and this glycemic index is a wonderful tool. It is a measurement of a food's ability to rapidly raise blood sugar. So foods that have a high glycemic index are bad for you. And so I just marked these. So what we try to do is get patients to eat foods that have a lower glycemic index. We use an index of 30 in our office, but it's different based on the patient need. You can also count grams of carbohydrates. And the point there is the more grams of carbohydrate you restrict, the more rapid the weight loss. And if you extremely restrict carbohydrates, it leads to something called measurable healthy ketosis. And this brings up the issue of the Atkins diet. Dr. Atkins was way ahead of his time. And he knew he was onto something, but I don't think he actually had all the science that he needed back then to demonstrate that it was a healthy way to eat. But now we have data that demonstrates he really was on the right track. And so there is nothing wrong with healthy ketosis. So there's some interesting effects when you talk to patients and get them to restrict their carbs. They go through carbohydrate withdrawal. And we actually refer to it as Carboholics Anonymous. It is identical to drug withdrawal in every sense of the shape of the description. The patient has a physiologic and a psychologic addiction to a drug that we call carbohydrate. And so we encourage them to reduce carbohydrates during this period of time, to eat high protein, high fat foods, drink lots of liquids. And if they feel rotten, and if they feel rotten, I tell them, that's wonderful. That's exactly the response that we're looking for. And hang in there. And I guarantee once your body learns to no longer rely on dietary carbohydrates and to burn body fat for energy, all of a sudden the energy will start to rise. You're not as hungry, you feel good, you're not eating as much food, and you're losing weight. So we need protein so we don't lose muscle mass. In the old school, they would say this is too much protein, but this is good. It does nothing to adversely affect kidneys. Now, fats. You know, I always say when I talk about fat and cholesterol, this is the punchline of the talk today. So, fats aren't so bad. I tell my patients that dietary fats are your friend, in contrast to the way that we've looked at it over the past 60 years. We all agree that there's healthy monounsaturated fats from olive oil, avocado, nuts. There's the essential fatty acids, EPA, DHA. So what happens is that if you're eating low glycemic foods, by default you're going to increase all the fat that you consume, both saturated and monounsaturated fat. But it's good because fat is filling. So it's a satiety, it's a way to make you full. And so let's talk a little more about the saturated fat and cholesterol. The way to describe this is how I describe it to my patients. Is I tell them that they can have a cheese omelet every morning at home. They can have a cheese omelet. The problem has been what we typically eat that with. And what we eat it with are the carbohydrates. The bread, toast, hash brown potatoes, pancakes, maple syrup, orange juice. And what happens now, as soon as we combine those foods, we raise glycemic index of the meal, we turn on the insulin, the switch, we absorb all those foods, and we drop dead from a heart attack. Okay? So it is the combination of fat, cholesterol, and carbs that kill us. But if you're doing this properly, you're avoiding carbohydrates, you're eating low glycemic, you're going to eat more fat, cholesterol, but the markers of inflammation improve. And I have another slide to show that in a minute. So we still have medication. Traditionally, there's the amphetamine derivatives, but we don't use them much anymore. What we're trying to do is use these physiologic drugs, and I had showed you this slide earlier, these hormonal drugs that are smart drugs that really treat insulin resistance. And we've had great success with these drugs. There are newer and future drugs. There's over-the-counter drugs. Some may hold promise, but they're not studied perhaps as much as some of the FDA-approved drugs. And of course, we treat the comorbid medical conditions. And then if all else fails, there's bariatric surgery, which is a viable option. Okay, so I think this is the fun part of evaluating diets. The first comment there is that it is inflammation. It's information overload, and that's why I'm here. I'm here to direct my patients and to set them in the right path. And I always say I don't know if the path that I'm leading them on is the right way, but I'm passionate about it. It makes more scientific sense to me than anything else I've looked at in my 19-year of practicing clinical medicine. And so when we look at the diets, we want to say, are they scientifically based? Are they considering medical concepts such as glycemic index, insulin resistance, inflammation? Are they looking at macronutrient content? Is it easy to understand? Do they include a long-term plan, a maintenance plan? Is exercise included? And so you can further compare diets, and it's simply based on macronutrient content. And what I do here is just to show the difference in diets. So we go from low-fat, high-carb to high-fat, low-carb. That's the spectrum. And so on the low-fat side, we have Dean Ornish and the Pritikin diet. Then we have Weight Watchers, Jenny Craig. Then we have Mediterranean diet, Sugar Busters, Suzanne Summers diet. It goes on and on. And then the ketogenic diets, Atkins and Bernstein diets. We also have bariatric diets. And you can go see a medical doctor and get yourself on a bariatric diet. And this is basically a traditional diet. I'm actually a member of this society. I do support them because there's a lot of doctors in the group that support carbohydrate restriction. But this is traditionally a very difficult diet. And most of these clinics, patients pay out of their pocket to achieve their weight loss, and they run out of money and they regain the weight. So it's not really a long-term solution. And then there's other crazy diets that we can't classify. And so what diets are healthy and safe? And I support any diet. If a patient comes in and they're having long-term success, that's great. But what happens to the markers of inflammation on any particular diet? So there's been studies, again, over the last 10 years. And what the studies show is that a carbohydrate-restricted diet improves the markers of inflammation. And they need to do studies over longer periods of time. But this is what I see in my office. I restrict patients' carbohydrates, and their cholesterol gets better, their high blood pressure gets better, their coronary artery disease gets better, and they lose weight and they feel great. I can't argue with that. The American Diabetes Association have included carbohydrate-restricted diets, but again, it's very hard to make big organizations make major changes. And I'm not going to wait for them to come out with the right recommendation. And again, we need more studies. So here's just one example of one of my patients, David, who has a website. He was a reporter, a writer, and he actually turned his health history into his writings. So he became a patient support person for the topics of obesity and diabetes. So he was struggling, and we actually met each other over the internet because I do a lot of internet support stuff. And he came in and saw me, and we put him on some of those newer diabetic drugs. This was Byetta, to help control his diabetes and his appetite. And 2 years later, he loses 153 pounds. Now, I always think he looks too skinny, but he's very highly motivated. And so presently, he's off all his medicines. We can't detect diabetes. So, when he goes into a doctor's office, there's no evidence of diabetes in this particular individual. And he's still keeping it off. He does a great job. It's a good slide.